behalf of my co-chair, Peter Nash, and all the faculty, I'd like to welcome all of you to this evening's symposium on translating data to clinical practice. I'm Ernest Choi. I'm Professor of Rheumatology from Cardiff University, and joining me on the podium today is Professor Peter Nash from Brisbane in Australia. So, Professor Peter Nash is from Griffith University in Brisbane, and actually he has done a lot of work related to Janus kinase inhibitors, both in terms of clinical trials and reporting some of the real-world data. So I'm delighted to be able to share the platform with him this evening.
Thank you so much, Ernest. We've got a lovely program for you today, both translating mechanisms, translating to clinical practice, and most important, everyone is so risk-averse now, a very nice safety session as well. And we have a lovely faculty. It's my honour to introduce, actually we should do the housekeeping things first. So there'll be translating data. Try that one there. Okay, so that's all the disclosures for everybody who'll be involved in the symposium today. And the long-term safety data will be discussed, the mechanisms for the different JAKs that impact that long-term safety, and some clinical considerations. They're the objectives for today's meeting, and we'd like some feedback at the end of the session, how you thought we fulfilled those objectives and your suggestions for improvements. So that's the that's the agenda that we have in mind for you. And if you scan the QR codes around the room, it allows you to ask questions at any stage that we can put to our speakers, but you're also welcome to come to the microphones and to ask your questions in person. All we ask is that you introduce yourself and where you are from.
Okay, so I'd like to introduce you, our stellar faculty this evening. Professor John Isaacs, my friend and colleague from Newcastle University in the UK, and Professor Roy Fleischmann from the Texas University in America, and Professor Ricky Alton from Berlin. So starting off the symposium, first of all, is Professor John Isaac. He's going to explain to us the mechanism of action of Janus kinase inhibitors to get us into the frame of the discussion. John.
Thank you, Ernest. Thank you, and thanks to the Cytokine Signaling Forum for inviting me this evening. So I'm going to talk to you about some of the science behind JAK inhibitors, and particularly I'm going to focus a lot on selectivity and the differences between the drugs. So this is a synopsis. So I'm going to start off with some basics. I'm sure you understand and know the basics, but I wanted to just recap a few critical issues. Then quite a middle section about comparing the JAK inhibitors and how they compare in the laboratory, what we measure, what's important. And then I'm just going to talk to you at the end about a JAK inhibitor that is different to the others in the way that it works. So the JAKs, the Janus-associated kinases, are so-called protein tyrosine kinases. These are enzymes that transfer a phosphate group from ATP onto a protein. So here's a protein kinase, and it's transferring a phosphate group onto this protein. That usually switches the protein function on. Occasionally it's off, but it's usually on, and often as part of an enzymatic cascade, a series of events, all depending on this phosphate transfer. They particularly associate with membrane receptors and provide key steps in signal transduction. What's important to recognize is this is a very common mechanism, so it's obviously a very successful mechanism, and there are 518 tyrosine kinases in the human genome, and they have proven to be tractable drug targets. So of those 518, the JAKs form just a very small family, so less than 1%, and there are 4 of them. They're called JAK1, JAK2, JAK3, and TYK2. They're structurally very similar, but they have subtle differences in their ATP binding pocket. So what does that mean? Well, first of all, I'll show you how they work, and then I'll tell you what the differences are. So how do they work? They're key factors for signaling of cytokines and growth factors. So here's a cytokine binding its receptor, and you can see the JAKs here in the tail of the receptor. Once that cytokine binds, the JAKs cross-phosphorylate each other. So this is the tyrosine kinase activity. They use phosphate from ATP and they phosphorylate one another. And as I said, there's then a cascade. So these phosphorylated JAKs are now active enzymes and they phosphorylate the tail of the receptor. The tail of the receptor then becomes a binding site for the so-called STAT proteins. Once they've bound, they become phosphorylated by the JAKs. And once those STATs become phosphorylated, they dimerize and they head off to the nucleus where they are transcription factors, and that leads to the production of pro-inflammatory mediators. So you can see it really is a cascade of tyrosine phosphorylation, several events, totally dependent on this ATP transfer. So this is the, if you like, the critical site within a JAK enzyme. So this is actually a molecular model of tofacitinib, and it's an overlay here. So in the green and red is where ATP would normally sit, and that's where the phosphate group comes from. But tofacitinib competes, and so you'd never get both there at the same time. So when tofacitinib is there, and the patient's taken tofacitinib, the ATP can't sit in its binding site, and therefore the enzyme becomes dysfunctional or inactive. And when I mentioned earlier on the subtle differences between the binding sites, so these 4 different JAKs have subtle differences here, which means that the clever medicinal chemists can synthesize compounds which have a stronger affinity, sit more comfortably in one JAK than another. And that's the kind of the concept behind selectivity. It's choosing which enzyme you want to block, creating drugs which block one rather than the other. So these are the pathways that we should be thinking about. And you can see, for example, up here on the left of the gamma chain cytokines, it's worth saying that the JAKs tend to, I always talk about hunting in pairs. They sit together in pairs, as I showed you on that cartoon just now, usually as heterodimers. So these gamma chain cytokines, which are the cytokines which tend to associate with T-cell activation and proliferation, associate with JAK1 and JAK3. The type 1 interferons, JAK1 and TYK2, the IL-6 family, JAK1, JAK2 and TYK2, so there's 3 there, although the JAK1 and JAK2 are probably the most important. Interferon gamma, JAK1 and JAK2, again, IL-12, 23, JAK2 and TYK2, and the only homodimers are the hematopoietic growth factors like erythropoietin, GM-CSF, which are JAK2, JAK2. So you can see that's why the chemists might choose to block one of these JAKs rather than other, and taking that a step further, a JAK1/2 selective drug like baricitinib, actually, although it's selective, will tend to be reasonably broad spectrum because all of these pathways include either JAK1 or JAK2, and I'll come back to that slightly later. There are also very non-selective drugs such as tofacitinib, which are JAK3, JAK1, a bit of JAK2, and even a little bit of TYK2. So again, they have a very non-selective profile. There are JAK1 selective drugs like upadacitinib and filgotinib, which won't block all of these pathways. There's TYK2 selective drugs, which I'll talk about at the end, which again have their own spectrum of effects. And then there's a JAK3 selective drug, which is licensed in Japan called pefacitinib, which will only block this particular pathway. And the rationale behind this selectivity, I guess it should be fairly obvious, is that if, for example, you think that a particular JAK pathway, for the sake of argument here, JAK1, is important for benefit, but a different JAK pathway is important in terms of adverse events, then what the chemists are trying to do is create a drug which binds more favorably to JAK1 such that there will be a therapeutic window. If you can get your dose right, you can block JAK1 in the patient without blocking JAK2. And that's what all small molecule drugs do, really. That's the basis of selectivity. And when we do our phase 1 and 2 studies, we're trying to find the dose that achieves this sweet spot, if you like. I think the important thing to recognize, though, is that as the dose goes up, selectivity will be lost. so you can see if the dose of the drug goes up, you'll start to increase the you'll increase the effects on the other JAK enzymes. So selectivity, we're used to using monoclonal antibodies these days, which are completely specific. So an anti-TNF only binds TNF. As I've said, there's 4 JAK members, so selectivity implies selectivity for 1 or 2 of these enzymes, but as the dose goes up, that selectivity is lost, and the enzyme will start to sit in the pockets of the other drugs. And indeed, if the dose goes high enough, you might even start to hit some of those other kinases in the human genome and get very strange off-target effects. So let's think about this a bit more. What do we really mean by selectivity? At its fundamental, you can imagine assays in the lab which literally have pure enzymes in an assay, and you can screen your inhibitor drugs against the purified enzyme and get a very pure readout of what that drug does in terms of blocking enzymes. But it's not as simple as that. We're human beings, we have a lot of differences amongst ourselves, and the drugs have to be absorbed, they have to reach our cells, they have to get into our cells, and that's where they do their work. So I'm going to go spend a little bit of time on this paper that came out last year. It's actually from Gilead Galapagos group, and the reason I want to show you it's a very comprehensive piece of work looking at the 4 licensed JAK inhibitors, at least in Europe, at their effects on different pathways in different cell types, either in peripheral blood mononuclear cells or in whole blood. And it's a very robust piece of work, I think. And I'll take you through it on the next slide as to what they do. But basically, these are laboratory assays. So blood comes either from healthy controls or patients. The blood is put into plates. It's then stimulated with a whole range of cytokines, many of those cytokines that you saw on the earlier figure, and then the JAK inhibitors are titrated into those plates, and the readout is how much inhibition of the STAT phosphorylation there is at the end of the day. And it's a complicated paper, but the reason I want to show you it is to show you the really diverse effects that these drugs can have. So the paper, with all the supplementary information, it goes for about 50 or 60 pages with lots of figures like this, and you won't be able to see this in detail. But what I want to try and explain to you, if we just look up here at the top right, in this particular part of the experiment, this is interferon alpha. So these cells have been stimulated with interferon alpha, and the readout is phospho-STAT 5. So that's one of the stats that gets phosphorylated. And then what's being modeled here is the blood concentration of, in blue, filgotinib, in red, baricitinib, in black, tofacitinib, and in green, upadacitinib. So this is the average blood concentration at 2 different doses of each drug, and this horizontal line is the 50% inhibition of the enzyme. So what you can see up here is that for interferon alpha and phospho-STAT 5, actually the 4 JAK inhibitors are not that different, and you won't be able to see these data, but this bottom line here is the number of hours in a day that the drug is inhibiting the enzyme by more than 50%, and it ranges from 12 hours to 24 hours depending on, in fact, from 5 hours to 24 hours depending on the drug, depending on the dose, but at the licensed doses it's pretty similar for the different drugs, and this is the average STAT inhibition during the 24 hours. And again, it's reasonably similar at the licensed doses. If you look down here, for example, this is GCSF, readout is STAT3 in monocytes, and here you can see differences. So the different drugs do have a differential effect on the inhibition of GCSF signaling in monocytes. And it looks like UPA's got the biggest inhibition, and over here, filgotinib's got the least inhibition. And I stress that in this article, they go through a whole lot of cytokines, a whole lot of phosphorylation pathways in lots of different cell types. And I'll come back to why I think that might be important. In summary, and I try to summarize, it's a lot of data to try and summarize, It's not quite as, it's nowhere near as straightforward as inhibiting those enzymes in the pure form of the enzyme in a plate in the laboratory. So for a start, it depends on whether they look at whole blood or PBMCs, because these drugs bind to serum proteins to differential amounts. The cell type's important, as you might expect. So if you look at neutrophils, they might respond to interferon more than monocytes. And so depending on which cell type, the drugs will have different effects. There'll be different receptors on the surface. Even within the same cell type, a different cytokine may be inhibited differentially by the same JAK inhibitor. And depending on what stat substrate you read out, you see differences as well. So I'm trying not to confuse you here, but I'm just trying to illustrate that it's complex. It's really not straightforward to say this JAK inhibitor does this and the other one does that. You can get a general hierarchy, and this is a figure from the paper. I showed you just now that in terms of interferon alpha, they do look fairly similar. And that's why in this top line, they're all marked down as 1. And then as you come down the table, the darker the square, the less the pathways being inhibited. So for JAK1, JAK2, this is IL-6. Again, they're all similar, actually. They're all pretty similar. What's interesting, so this is JAK1, 2, IL-6 in monocytes. This is JAK1, JAK2, interferon gamma in monocytes. And you can see here they're starting to differ a little bit. So it's the same JAK1 and JAK2 you're inhibiting just in terms of different enzymes in the same cell type, and you're now starting to see discrimination between the drugs. And it might be that interferon gamma, for example, signals more down the JAK1 side of the JAK1, JAK2 pathway, and perhaps IL-6 signals more down the JAK2 part of the JAK1, JAK2 pathway. So although those JAKs are in heterodimers, it doesn't mean that every cytokine signals the same amount down each part of the heterodimer, and that's part of the complexity. And then as you come down here, here's JAK2, JAK2, and you can see filgotinib, for example, doesn't really block that pathway very much because it's more JAK1 selective. And this is one of the filgotinib metabolites that I should have mentioned earlier on. So depending on what pathway you look at, you will see differential blockade. And that's shown on this next slide, which is equally complicated. And it's not here to tell you details, but again, we've got filgotinib at 2 doses, tofacitinib at 2 doses, upadacitinib at 2 doses, baricitinib at 2 doses. And this is the average inhibition over 24 hours on the left, and this is the hours above IC50 again on the right. And the sorts of things I can show you here, as you would expect, the bigger dose of each drug causes more inhibition of the pathways, and you actually start to lose selectivity as the dose goes up, as I've explained earlier on. And if you look down in this bottom half, perhaps one of the biggest differences is that filgotinib over here, baricitinib over here, seem to be inhibiting the JAK1, JAK3 pathways a little bit less than tofacitinib and upadacitinib do. So there are differences between drugs, but I really show you this figure to show how much effort has gone into this paper, and this is just one of many figures that look similar. So other considerations, does blood reflect tissue? And I've already told you that the drugs have to get into the tissue, and that depends on pharmacokinetics, pharmacogenetics, adherence. The thing that often bugs me, though, is this IC50. It's a pharmacological concept. It's what the pharmacologists use. But if you're blocking lots of pathways in lots of cells, maybe IC50 is not that important. You know, maybe much less blockade is relevant. So going back to this figure, if you look down the bottom here, what if only 20% inhibition was important? Then in this bottom left figure, you get a kind of different profile. And if you imagine all these different pathways in all the different white blood cells, even 10% inhibition might be relevant. So in my head, the whole concept of selectivity based on IC50 may be much less relevant in terms of the whole patient with all these different pathways and lots of different cells. And I guess the other thing is, which pathway do you want to block anyway? I'm not sure that we really know out of all these JAK-STAT pathways, which are the ones which are really, the ones that are most beneficial. As I said, in Japan, we've got peffercitinib that only blocks this pathway, and that works, whereas a drug like baricitinib blocks a lot of the different pathways, but is also effective. Just to finish off, so I hope I haven't really confused you completely, but my point is I'm not sure we necessarily understand the concept of selectivity. I'm not sure we really understand the relevance in the whole patient, particularly when you take into account things like absorption and excretion and pharmacokinetics and pharmacogenetics. Just to finish, though, deucravacitinib, I wanted to mention it is different to every other JAK that I've told you about because it doesn't sit in the ATP binding pocket. That's where it's different. So TYK2, which is the fourth JAK, has what's called a pseudokinase domain. It's in yellow here. And this inhibits the kinase domain. It's an evolutionary related to the kinase domain, but it regulates receptor-mediated activation. And basically, deucravacitinib stabilizes this enzyme in the off position. So it binds to the pseudokinase domain and allosterically inhibits the kinase domain. So it's a different type of mechanism of action to all the other JAKs. And because of that, it's really highly selective and it's potent for TYK2. So this is a very selective drug purely because of the way that it works. So if you block TYK2, you're going to block the IL-12/23 pathway, you'll block interferon alpha, and you may block a bit of IL-6 pathway as well. And this drug has been looked at in terms of our diseases in psoriatic arthritis. I won't go into detail, but it looks pretty effective. This is ACR 20 at 2 doses of deucravacitinib. This is the HAQ score going down over a 16-week study. So that's a different JAK, which I'm sure we'll hear much more about as rheumatologists, works different to all the others. So in conclusion, the JAK inhibitors do have different selectivities. It translates into distinct ex vivo and in vitro profiles. The challenge, I think, is to decide which aspects really matter in the clinic and what do they impact on efficacy, do they impact on safety. I haven't gone into pharmacokinetics and pharmacogenetics in this talk, but they will both influence how much drug you get into your system, and it probably determines why different patients respond differently to these drugs. I've put don't forget the precision medicine agenda, because even though these drugs may have different selectivity, it doesn't tell us which ones to use in which patients, and that's a big part of the agenda these days. And at the end there, I've just talked to you about deucravacitinib as a drug which does have a different mechanism of action. So I'll leave it there, and thank you for your attention.
Thank you, John. You can ask questions from the microphone or using the app. Here's a question. Introduce yourself, please.
Insisting about selectivity, and in this clinical trial, there is no big difference. Even UBA inhibits JAK2, TYK2 more than the other, and we should concentrate on pharmacokinetics. Does it mean one is metabolized through the liver, one is secreted through the kidney? And we have to stop to use the term selectivity, because I myself, don't believe in this. I'm Osama from Saudi Arabia.
I'm not sure I quite caught all of that question.
It was a question whether selectivity is a real thing and whether we should be looking at the PK, PD of individual patients.
Okay, I think that's kind of what I'm saying, really. Selectivity is a real thing. These drugs are definitely different. It just depends how you measure it. I sometimes talk about personalized medicine rather than precision medicine, because what you're saying is, to me, is personalized medicine. You have to take into account the patient's age, the kidney function, the liver function, all sorts of parameters which are really important in how we treat patients. I think the jury's out. I don't know whether selectivity is important. It'll be interesting to look at a drug like deucravacitinib, which is different to the others in terms of its selectivity, and see how that looks compared with the other JAK inhibitors.
Thank you.
So, John, do you think there's room for more JAKs? Should we have 4, 5, 6, 7, 8? And if one's 100 times more selective, do you think one day there'll be 1,000,000 times more selective?
It depends how clever the chemists are, really, but I think there's room for more. Honestly, I do. I think that... Now, I run a refractory clinic for patients that haven't responded to lots of drugs, and if I cycle these drugs, patients respond to them in sequence, and so they don't all seem to be doing the same thing. And whether that's got anything to do with selectivity or the pharmacokinetics, I'm not really sure. But our patients need more drugs. These drugs work well. And so I think, I think we certainly have space for more.
Thank you very much for a very clear presentation. So it's my pleasure to introduce Roy Fleischmann, who is a professor of medicine at the University of Texas Southwestern Medical Center in Dallas. He's a master of the College of Rheumatology. He's been involved in all the pivotal registration studies for all advanced therapies going back over many years. He's a supreme educator and mentor to many young rheumatologists around the world, and we're very fortunate to have him here to explain to us the safety of JAKs. Thank you very much, Roy.
Thank you, Peter, and thank you for inviting me to give this talk. John, that was a very interesting talk. I'm going to disagree with you, as you'll see. So my charge was to talk about safety, and this is a slide I show all the time. If it isn't safe, and I keep doing that, if it isn't safe, I don't care about efficacy. You really have to have pretty good safety. So here is a safety profile of JAK inhibitors in clinical trials, and I'm not differentiating one from the other. We do see infections, we see SIEs, we see herpes zoster, opportunistic infections. The herpes zoster clearly is a little bit more prevalent with the JAKs than it is with biologics or the conventional synthetics, but the SIEs and the opportunistic infections are not. As John pointed out, because the JAK2, you can see rare anemia, but you can also see neutropenia, lymphopenia occasionally. And you certainly see elevated LFTs with these drugs, particularly when they're used in combination with the conventional synthetic DMARD. And for some reason, with all of the JAKs, you do get a mild increase in serum creatinine, but having looked at the data safety base of all of the JAKs and all of it, I don't think I've seen a single patient who's run into real renal problems with any of the JAKs. It's a small increase in creatinine. And the other, it's an occasional increase in CPK, but it could be 10–15% of patients. It could be mild, and it could be thousands. But again, and the reason for this is probably the re-innovation of muscles that have not been innovated for a while. But again, I've not seen a single patient or any report of a patient who's really developed a true myopathy. GI perforations have been reported. One of the cytokines that John showed is affected is IL-6. So you think about that. Hyperlipidemia occurs with all of the JAKs as well as with the TNFs. The reason for this with the JAKs is twofold. With the TNFs, it's actually getting the inflammation under control. That occurs with the JAKs as well. But the JAKs also change the cholesterol esterification. And the particles that they produce are high particles. And you would expect that the JAKs would be protective for MACE, looking at the data that we've developed previously. But MACE does occur, and we'll talk about that. Malignancy does occur, we'll talk about that. We know that the malignancy, the standardized incidence ratio versus the SEER database is about 1, but there are malignancies that occur more frequently, like lymphoma and lung cancer, as they do in rheumatoid arthritis, and there are others that occur less frequently, like in cancer of the bowel. And it's been documented that venous thrombotic episodes can occur as well. But let's talk about this, and let's talk about MACE malignancy and VT in the general RA population, registries and clinical trials. What do we know about these before? So this is a slide that has a lot of references, and what it says is cardiovascular events in patients with RA, increased cardiovascular events occur in patients with active RA, correlate with traditional risk factors, and inflammation and disease activity. We know that. And then we know that conventional synthetic DMARDs and biologics like TNF reduce the risk of cardiovascular events by at least 50%, And reduction of disease activity over time is associated with fewer cardiovascular events. Lots of references. This has been known for 20 years. What about reduction of MACE? So the TNFs reduce the incidence of cardiovascular events and mortality better than conventional synthetics, and it's by reducing chronic inflammation, with no increased risk of malignancy compared to conventional synthetic DMARDs. Well documented. But here, head-to-head trial of etanercept was done versus tocilizumab, and that was the INTRACT trial. Interesting trial. The incident rate of the first events of MACE with etanercept was 1.70, and I want you to remember 1.70 with Etanercept in a trial that's similar to oral surveillance that I'm going to spend, versus 1.82 with tocilizumab. So tocilizumab raises the lipids just like the JAKs, but there was no difference between Etanercept and tocilizumab. Incident rate 1.7, and the hazard ratio was about 1. Lymphoma and RA, old data, increased disease activity, more lymphoma. Less disease activity, less lymphoma. VTE and RA, in RA versus the general population, rheumatoid arthritis itself is associated with VTE, PE, right? DVT, a factor of about 2. Active RA is really bad for VTE. What about disease activity? This was published about a year ago. The VTEs reduce as inflammation gets under control. High disease activity, more VTEs. Remission, much less. Disease activity. And we're going to talk a lot about tofacitinib, but I wanted to throw in another JAK. I wanted to be really very fair. So this is an integrated safety profile of upadacitinib. And if we take a look at malignancy, what you can see is there's no difference in the general RA population in the clinical trial database for upadacitinib 15 milligrams or adalimumab or methotrexate in RA or PSA or ankylosing spondylitis. No signal, 0 signal. MACE, no signal. VTE, no signal. CPK and herpes zoster there was, but not for these, right? And then going into the corona registry, like most registries, there are real problems looking at registries, but there are things that you can take out. This was post-marketing for the FDA. Tofacitinib, patients started on tofacitinib or biologic, the dark circle is tofacitinib, and what was the incidence of MACE, serious infections, herpes zoster, malignancies, non-melanoma skin cancer, and death. And what you see is that for herpes zoster, clearly, right, increased incidence of herpes zoster, but in the general RA population, there was actually more MACE with with the biologics than with tofacitinib. Confidence intervals overlap, but numerically more. SIEs, a little bit more with tofa, confidence intervals overlap, but no difference at all with malignancies, non-melanoma skin cancer, or death. So now this is tofacitinib real-world evidence. I know you guys love real-world evidence, and it shows no difference. What about oral surveillance? So oral surveillance, and you've seen this probably 87 times at this meeting. Post-marketing requirement, looking at the relative risk of tofa versus TNF inhibitors, looked at increased risk of MACE and malignancies in patients with RA. And it was a prospective study, non-inferiority study, open label, safety endpoint. And the co-primary endpoints were the non-inferiority of tofa compared to TNF, adalimumab in North America, and Etanercept in the rest of the world with respect to MACE and malignancies, and it was defined by the upper bound of the 95% confidence interval, the hazard ratio not being greater than 1.8. It's how the FDA defines safety. Here's the study design. You've seen it before. Tofa 5 milligrams BID plus methotrexate, 10 milligrams plus methotrexate, TNF inhibitors. They had active RA. They had to be at least age 50. They had to have at least one cardiovascular risk factor. They had to be methotrexate incomplete responders, continuing methotrexate. They couldn't have had prior malignancy. And it's an event-driven study. At least 1,500 patients had to be followed for at least 3 years. There had to be at least 103 MACE and 138 malignancies. And here's the results. And the result is, if you take a look at this upper bar, the incident rate for, and it was combined tofa, the incident rate for the combined tofa was 1.13, or the, not the incident rate, but the confidence interval, but the upper limit of the confidence was 1.94. Higher than 1.8, the combined dose tofacitinib, not similar to TNF. So the study failed. If you're Pfizer, it failed, right? But I want you to take a look at the incident rate. So the incident rate here is 0.91 for TOFA, 5 milligrams BID. We know in TRACT, etanercept was 1.7. Boy, this is going to be a great win for TOFA. But in this trial, it was 0.73. Almost exact same trial as the TRACT, but this is 0.73. The incident rates are low, numerically a little higher with TOFA, failed, not statistically significant, but missed its primary endpoint. And you have to take a look at the number needed to harm. And the number needed to harm for the 5 milligram BID dose is 567. You have to treat 567 more patients with tofacitinib 5 milligrams BID to have one more MACE event than with the TNF. And here's the MACE. And this is old data now, because this is now showing over 65 or ever smoked, and that was originally, when we put this together a month or two ago, before we saw the abstracts for EULAR, that's what it was. It really isn't. It turns out that MACE is, did you have a cardiovascular event? If you did, you're at high risk. Do you have a high risk of a cardiovascular event? If you do, that's high risk. If you smoke and older, that's also high risk. But it's the cardiovascular event that really drives it. And this actually shows it, right? So here's a history of cardiovascular disease, an event, and you can see that really raises the incident rate. And this is high risk for MACE, intermediate rate, borderline, low risk. It's dose related, right? And incidentally, this pink is TNF. Oh, TNFs raise the risk as well. So does tofacitinib. Very similar, not statistically different. Confidence intervals overlap. And that's an important point that I want to get across to you. It's true that there is increased incidence of cardiovascular events, MACE, if the patient had an event before, has a high risk, smokes over 65, but it's not different, really different, numerically a little bit different for TNF versus TOFA. And if you're treating a patient with a TNF and they have those risk factors, you better mitigate that as well as if you can treat with TOFA. The agencies don't say that at all, but it's true. Here's malignancy, same thing. Upper limit of the confidence interval, 2.09. Number needed to harm, 276. So numerically, a little bit higher with TOFA than TNF, not statistically different, but numerically a little bit higher. What was the risk for malignancy? I was shocked when I saw this. So it was lung cancer in smokers. I never knew that smoking causes lung cancer right before. Of course I knew that. Lymphoma, breast cancer was the most common ones that you saw with the TNF. And here you can see it really is smoking, right? But there's also some indication that cardiovascular disease is also related. So this is smoking, and it's age. VTE is very interesting because here there is a dose effect, and the 10 milligram clearly is higher than TNF. But the 5 milligram, the incident rate is 0.3 versus 0.2. DVT, 0.2 versus 0.1. Yeah, it's numerically higher, not statistically, and the number needed to harm for VTE is 763. You have to treat 763 more patients to have one more event. What drives it? Before I say what drives it, this data has been out. You've also seen this with MACE. The incident rate doesn't increase over time, neither for the TNF or for tofacitinib. If TNF or tofacitinib were really related to VTEs, I'd expect it to increase over time. I don't see it. And what drove it? History of VTE. If you had a history of VTE, I don't care if you're on TNF or TOFA, your risk was really high. If you didn't have a history of VTE, it was really low. Patients actually did pretty well with disease activity, but not all the patients. And actually, most of the events of VTE were in patients who had moderate or high disease activity or low disease activity, but not remission. So remission, disease activity also is important in this. So what did PRAC recommend? PRAC said if you have a history of serious infections, MI, malignancies, over 65, use tofacitinib only if you can't use anything else. Not unreasonable, because the JAKs are about equal to the TNF in efficacy. Baricitinib and upadacitinib maybe a little bit better, tofacitinib about the same, but about the same. And if numerically there's a little bit of difference, use a TNF. It's not unreasonable. This is going into the databases, and I've heard from companies, oh, we've only seen the data with tofa, my drug doesn't do it. I don't believe that. Here's herpes zoster, serious infections, malignancy MACE in the databases, and it's exactly the same for all three drugs. So yeah, the test tube, they're selectively different, right? Not in safety and not in efficacy. So it's different, but not that different. All right, so FDA did something different, and I'm really running out of time. I'm going to say that the FDA said safety first. The TNF was a little bit safer, therefore you can't use a JAK, any JAK, before you use a TNF in any disease that you use a JAK. RA, psoriatic arthritis, ulcerative colitis, atopic dermatitis, even though it's topical. Ulcerative colitis, right? That's what they said. So this is my last slide. It's going to be my last slide. I'm going to answer questions about surveillance, because surveillance didn't answer everything. If I did the study again, would I get the same result? I don't know. And TRAC got a different result for MACE. Maybe not. Is the numerical risk only in this high-risk population of over 65 with a history of smoking? No. It's over 65 with a history of smoking with events, cardiovascular events, or risk of cardiovascular events, or VTE. We're getting more and more specific. It wasn't the whole population. Were events seen only in patients with disease activity? You had to have disease activity to have an event, but that probably wasn't the only driver. And I showed you the incident rate didn't increase over time. Why? Is it the drug or is it the disease that we saw these events? My guess is the disease, not the drugs. Does tofacitinib lower the risk of MACE, malignancy, and VTE, but not as well as TNF? The study doesn't address that. There was no control arm, conventional synthetic, for 5-6 years that would tell you that tofacitinib had a lower risk of these events. But I showed you that conventional synthetics reduce the risk. I showed you TNFs reduce the risk. I showed you the incident rate was really low. I showed you that in the untreated population, the risks are at least twice as high. I think this is 2 and 2 is 3.9. Tofa reduces the risk, but maybe not quite as much as a TNF. Is it superior to conventional synthetics? Can't answer the question. We didn't do that. What about other mechanism of action, right? So versus the TNF, fine. What about an IL-6 inhibitor? What about an anti-co-stimulatory molecule? What about a B cell? I have no idea. It wasn't done in the study. And now the FDA says it's all diseases. But what if this was done in PSA, which is different than RA, or ankylosing spondylitis, which is very different? The patients are very different. Or ulcerative colitis, where they're really, really different. Would you have gotten the same results? I don't know. Are they class specific? Is the FDA correct when they said it's all JAKs? I think that's true. I think that's probably true, right? I can't prove it, but I think it's true. But how clinically meaningful are these? So I showed you the number needed to harm. We said that, yes, it's a little bit increased, but the number needed to harm is really high. The number needed to treat is really low. In an individual patient, is it worthwhile to use a JAK rather than a TNF? It's up to you to decide. And I'm going to stop here because it's pretty clear as to who you shouldn't treat with a JAK. Someone who has high risk of these events, right? And then what else I have here, and who should be treated, who could be well, if you haven't responded to a TNF, even the FDA says it's fine, right? Or if the patient can only take monotherapy where the biologics don't work well as monotherapy, maybe there you use a JAK or an IL-6. But whoever it is, you have to know what oral surveillance said, the patient has to know what oral surveillance said, and you both have to be comfortable with it. And with that, I'll say thank you.
Thank you very much for taking us into a very detailed deep dive into the interpretation of those safety data. There's a question online, which is, do you think we can use smaller doses in high-risk patients? Do you think you'll make it?
So the answer is there are patients that I have who have adverse events from TOFA, which could be the diarrhea, could be the headache, which I've had before, who responded to 5 milligrams BID, reduced the dose to 5 milligrams a day, and they continue to respond. And individual patients, I'm sure that's true. I do think that the correct dose of DOFA, if Pfizer had done the right dose ranging study, that would have been approved, or should have been approved, probably 7.5 milligrams BID, right? That probably would have been better. So are there patients who would respond to 5 a day? I'm sure it's true, but there are patients that won't.
Great, thank you. I think we can take that into further discussion when we have the panel discussion a bit later on. So in the interest of time, let's move on. And my good friend, Professor Ricky Alton from Berlin, is going to talk about how to translate these data into clinical practice. So you have the hot question.
Thank you very much, Ernest, for the kind introduction. And my topic today is translating data to clinical practice for the use of JAK inhibitors. And I thank you very much, especially to the Cytokine Forum, that they give us this opportunity to see it, what all the data we have heard so far are useful for clinical practice. These are my conflicts of interest. If you memorize one of the pictures of John, you can see the tiny little molecule in there. So clinical trial and real-world data, evidence data, suggests the possibility to further enhance the patient experience in terms of patient-reported outcome. And I'm personally very much interested in patient-reported outcomes, and we assess them regularly in my clinic for many years already. And I can share with you that this is an open book, but you just have to do it. We had a German meeting in April, and in one room there were 400 German rheumatologists. And one of my colleagues, I didn't do this, intentionally not, asked, how many of you are regularly taking patient-reported outcomes? You know, there were 3 who were so honest to show that they are doing it on a regular basis. And if we don't do it, we will never learn what the patients think, what the patients feel, and this explains so much, really, from our daily work, like discordance and other things we will cover in a minute. So one of these topics is also pain, and pain improvement, which may exceed the benefits previously attainable with biologic anti-TNFs. And this is why it is so important to evaluate the benefits we have since we have the JAKs in our hands, because somehow this has brought a paradigm shift to us. We know many information about baricitinib. It is approved for rheumatoid arthritis, for atopic dermatitis, and also for COVID-19. And what is interesting, that the unexpected side effects are more in the RA population than in the population with atopic dermatitis. The population with atopic dermatitis is younger, but I always want to show that patients with rheumatoid arthritis, especially with double positive, seropositive and ACPA positive rheumatoid arthritis, are a very sensitive population, and we have to look very careful what are the characteristics of these patients. This is an overview, and we have seen this nicely already by John Isaac, so I don't have to go into details. The pefacitinib we still have only in Japan, but we have, besides baricitinib, 3 other JAK inhibitors which we can use, for instance, in Germany. So I go back to the patients. The patients still, despite we have many treatment options, have unmet needs. So most patients agree that setting a treatment goal does not take place in a shared decision manner. And we have heard 2 days ago by Josef Smolen with the new EULA recommendations for treatment patients with rheumatoid arthritis that this sentence, to perform shared decision-making, has been unchanged. It has even been stressed. But you can't practice shared decision-making without listening to the patient, without knowing what are the individual needs of the patient. For me, in my daily practice, I'm assessing it with the rate because it's very easy. Fatigue is one of the most important feature of the most important unmet needs of our patients. Pain just follows, and then comes physical well-being and also physical function. There are many symptoms and domains. They are of paramount importance for our patients, and we are not always taking them into account if we are going to make a treatment decision. The patients have a very nice wording for this. I want to have a good day. This we know already from a former survey. Now they say, I want to have a day free of pain and fatigue. So another survey showed that up to 74% of the patients are not satisfied with the actual treatment. And more than 30% of the patients don't believe there are enough treatment options for them now and also for the future. And there's also half of the patients who are not happy with the management, what we do with their disease. So when we saw for the first time the data from the New England publication by Peter Taylor for the rapid improvement of pain and also the function here on the right side of the panel, we couldn't believe it. That was really something very new for us. You want to remember that it was a very rapid relief of pain, and the relief was sustained. And even if you go to further elongation of all these studies, that has been remained. These are the 52 weeks data, but we see any more. So if I refer to Osler, actually I learned yesterday that Osler was from Oxford. I didn't know this before, but he has phrased what we also used in Almaract. The good physician treats the disease, but the great physician treats the patient who has a disease. Although we have established already treat to target in 2009, and everybody knows the nice graph which was drafted by Josef Smolen, we still look for the arrival of effective biomarkers in the precision medicine that can reliably inform the management decisions. And also the next question is, what about the patients and the personalized medicine? What are the different criteria who allow us to give a certain medication without any harm to our patients? So coming back to pain. For patients, and we have shown this in many publications, pain is the greatest contributor to the perception of their disease activity. That correlates very strongly with the patient's global. And for physicians, and there are many famous physicians which are not in the room now, but they helped us also defining our Almaract FLAIR definition. They told us, and we showed this nicely in our publication in the context of FLAIR, that only swollen joints is the greatest contributor to perception of the disease activity. And this explains so much that patients and physicians are not always on the same planet. So another question is, how is the relative contribution of the inflammatory control to pain control? And you can see on the right side of the panel also the comparison of the pivotal study, the BEAM study for Bari and adalimumab. And you can see here that there was a much better pain control by the patients who were put on baricitinib and had a more rapid change in pain. And if the patients have a rapid change in pain, I think we have to take into account what we heard the day before yesterday. Again, EULA has come into terms with glucocorticoids by now. And that is why Josef Smolen told us we should not only taper the glucocorticoids, now the mission is to stop the glucocorticoids. If you look all over the place for the demographics of all randomized clinical trials, for all the JAK inhibitors we have, the patients have a disease duration of 10 years, And more than 50% of all these patients are on glucocorticoids. And we don't have any information how the glucocorticoids in this trial were reduced, because that was not part of the trial protocol. And I think, hopefully, the mission we learned from Joseph 2 days ago will be translated into clinical practice, that we can stop the glucocorticoids, and the only drug with which we can stop the glucocorticoids rapidly are indeed the JAK inhibitors, because of their rapid efficacy. So there are other mechanisms contributing to the pain, especially morbidity and other contextual factors. It will be too much to go into detail now, but they are also under investigation. There are many multifactorial points which have to be taken into consider, as in all other chronic diseases. So another data here from BEAM, you can see that it was significantly faster, the median time to achieve a 50 or 70% of pain improvement with Bari, compared either to adalimumab but also to placebo. This is to underline my idea that if we are going to select the right patients for the treatment with Janus kinase inhibitors, then we can have a rapid pain control, a pain improvement, relevant pain improvement, and then we can really try not to reduce, to taper, but really to stop the glucocorticoids. Yesterday morning, there was a very, very nice talk of our German rabbit cohort. Maybe some of you have heard it, by Yvette Meissner. And she showed, and this is very clear for me, more than 3,000 patients on baricitinib, and they saw no signal at all. What is the reason for this? It is not a randomized trial, because the patients are not randomized. But the good rheumatologist knows already, and these data are from the last 4 years, as far as I remember, which patient is the right patient for the Janus kinase inhibitors. We have learned so much already, and also the other real-world data, which I will cover in a minute, show us this. Again, pain and physical function are very much improved under the treatment on those patients who did not respond to methotrexate over year 1, and these are also very reassuring data. I don't want to go into detail, but the HAQ-DI is important. If you have a 50% reduction in HAQ in the beginning of your disease, we did this data for the German insurance companies and also for the pension funds, 50% of these patients are less than 5 years later in total pension. HAQ is a very good predictor for this, and if you improve the HAQ nearly to normal, then many patients can move on working. So I want to present to you also the data of a nice study. It is also shown on the poster 666 here at EULA, the 1-year data, but today I show you the data why we did this study. So BeReal is a planned 3-year prospective observational study in adult patients with rheumatoid arthritis, evaluating the adherence to the treatment in clinical practice. We wanted to report the proportion of European patients with rheumatoid arthritis who discontinue their treatment after months 3 and 6 of Bari or biologic or any other targeted synthetic DMARD. The treatment was started at the discretion of the physician, really a real-world study, and we wanted to assess also changes from baseline in CDAI and describe changes in other patient-reported outcome related to quality of life, pain, and physical function. So this is the study design. You see 2 cohorts. Cohort A in red is the Bari cohort. There were 2 dosages available for the patients, 2 or 4 milligram, and cohort B are all other biological or TSD maps. So the method, the enrollment period was from March until March 2020, from October 2018, and our primary endpoint was defined as the discontinuation rate of initial RA treatment for all courses. Then the cohort A, as I mentioned already, started treatment with Bari, and the cohort B, any other bio or TSD MAD. In this first shown interim analysis, we have seen 3 and 6 months data from 5 European countries, from France, Germany, Italy, Spain, and the United Kingdom. And you can see here the results. These were the assessment we were going to take: CDAI, swollen joint, tender joints, pain, but also Patients Global and Physicians Global, HAC-DI, and for quality of life, we decided to use the EQ5D because it's very practical, and we have it also in our German national database so we can compare. These are the baseline characteristics of the patients, a typical population with rheumatoid arthritis. And again here, many patients are, despite the fact that they have a long disease duration, are on oral glucocorticoids. This is what we have to take into account when we make decisions. And I think also for the safety events, the glucocorticoids play an important role. So the percent of patients who discontinued in the treatment at month 3 and 6 was much lower in the group of the BARI group, in the cohort A, compared to the group with the other treatment arms. And also what was interestingly achieved was that there was a higher percentage of patients in cohort A and B achieving remission and low disease activity at month 6. And I was able to show the data also for year 1 at this EULAR in the poster mentioned already, 666. So the observed mean and changes from baseline in all our domains were very reassuring, and there were really good results, so that I can conclude in this descriptive analysis of our European patient cohort of this study, the following conclusions could be drawn. Patients treated with baricitinib were more likely to be refractory, had received more prior treatment with more than 2 biodemats or others, and received monotherapy, more than half of the patients. And despite this difficult factors, difficult to treat patients, D to T, patients receiving baricitinib were less likely to discontinue the treatment and more likely to achieve remission or low disease activity than patients receiving biodemats or other TSDMATs. Where here I could stop, but I brought some other overview for you. This is the real evidence we have at the moment, and there is one very nice publication from Italy, which I only would like to mention now, and they have shown that their patient group, 500 patients, could not only also achieve low disease activity or remission, but they could, in this cohort, taper the glucocorticoids to 0 within 6 months. And I think this is the most important information. And who has attended this morning the JAK presentation by Axel Fink knows that we are continuously following also here their results, because they are independent and give us a very, very good confirmation of our own data in the BeReal study. So I presented these data already at the ISPOR 21, and I'm hopefully presenting the follow-up data for more than 1 year this year at ACR. And by this, I would like to end, and thank you very much for your attention.
So thank you very much. We have about 10 minutes for questions, and we have a number of questions here. There's one to Professor Fleischmann. Are further trials going to be necessary to better define the relative risks of TNFs and JAKs? Roy, what do you think?
I don't think so. First of all, they can be very costly, very difficult to do. I don't know that anyone would do it, but I actually don't think so. The relative risks were very small, as I pointed out. I think that what we need to know from oral surveillance is actually an in-depth look to see who were the real patients who really were at risk. I think if we can identify that, and I think we will, I think that will be true of all of the JAKs and all of the TNFs and all of the biologics. And that's what you're missing. What you're missing is you think this is only tofacitinib. It's not, right? It's the JAKs, it's the biologics. But I think an in-depth analysis of oral surveillance will give us the answers.
Actually, I just want to echo of what you just said, Roy, because I usually teach my students the difference between relative risk and absolute risk. I said that if the lottery company said that next week we're going to double your chance of winning the lottery, how many winners will you have? And the answer is still 1, because the background probability is so low, just doubling the risk actually doesn't translate into an additional winner. So then that absolute risk is really important to explain that to the patient.
And it's low.
And it's low.
There's a question here for Professor Alton. If these drugs don't cross the blood-brain barrier, how do they work on pain?
Pardon? How?
What's the mechanism for pain relief if they don't cross the blood-brain barrier?
Pardon?
They don't cross the blood-brain barrier. How do they affect?
Well,
Ernest, do you have an answer?
yes.
I can think about it, but I give you the word.
So actually, if you were in the session just now on musculoskeletal disease during COVID-19, it was a very elegant discussion to show that the dorsal root ganglion, which controls many pain, and you can see that many cytokines actually activate the dorsal root ganglion, that is not privy to the blood-brain barrier. Most of the cytokine can access the dorsal root ganglion.
And that's especially IL-6 and GM-CSF, and you can actually see the spinal cord, peripheral nerves. It doesn't have to cross the blood-brain barrier. And we think when we wrote the paper with Peter, we thought that that was actually the reason why you had the pain relief.
Actually, I think pain is a very complex construct, like fatigue, and you cannot unidirectionally say it comes from there or there. And especially what I learned in my clinical practice, that you are going to have pain-prone patients, you know. They have the construct of pain, and for the first time, if they get a specific therapy, they see that the pain has changed. And that is very important in their disease perception. And for them, that is the opening the door that they can really, for the first time in their life, see that pain is changeable.
There's a question here for Professor Isaacs about dose. Do you think reducing the dose of Barry from 4 to 2 will give you a nicer balance of selectivity and efficacy?
It's a great question. I meant to point it out actually on that heat map, actually, the 2 milligrams of Barry. Again, if you believe IC50, doesn't do very much, which is why I don't really believe IC50. I mean, so maybe Roy should be answering that because that's what you use in the States. So I don't know what you find with 2 milligrams of Barry.
Well, I don't use it actually. So the question is, if reducing it to the 2, would you be safer? Because of selectivity. Because of selectivity. So what I said about John, what John said was 100% true in the test tube. Every test tube doesn't lie. And the cells, it doesn't lie. But you need to know the clinical trial program of varicitinib, which did have the 2 and 4. So actually in the phase 2, they had a 1, 2, 4, and I think it was 6. The 1 milligram was effective. The 2 milligram was not. The 4 milligram was effective. So Lilly decided to go with the 2 as the dose that wouldn't work and the 4 that would work. And Lilly really ran into a problem because the 2 did work. But however, that was the methotrexate IR. They only did it in 2 studies. In the study that was in the TNF failure, the 2 milligram really wasn't as good as the 4. And so the perception we have in the US is, yeah, you can respond to 2, but the 4 is much better. So when I speak to my friends around the world, the 2 friends I have, like Peter and Yoshi Tanaka, who have had this drug, what they tell me is they actually start with 4, and then they may go down to 2 if the patient feels well, or if the GFR is low, then they start at 2. So you think about the lowest dose, but the question is, why? If the patient's not having a problem with the dose that's most effective, why? If they are having a problem, sure, you can try it. But with Barry, and with Topher as well, the full dose is probably best.
I mean, I think the direct answer to the question is the lower dose is probably safer. I mean, I think that's true of any drug.
I don't think that there was much difference in safety between 2 and 4. There was a little bit. There was a little bit, but I don't think there was much.
But
We also have to take into account the interesting data from Japan. Takeuchi did the study where they were on 4 milligram. Then when they were in low disease activity or remission, they reduced to 2. And all patients who put again, it was only 1/3, were put again on 4, and they recaptured their disease state from before. That's also interesting.
On that point,
so Takeuchi reported that. He didn't do the study. We all did the study. So the issue is those patients who came from RA Begin, the first study that I published, had to be in CDI remission. And the patients who were incomplete responders had to be in low disease activity. And then the question was, could you reduce the dose and maintain it? And as we said, yes, there were patients you could reduce the dose and maintain it, but there were many who you had to go back to
Who
full.
fled.
It shows the same thing.
But it's interesting.
Yeah,
Yes, it is interesting.
I think Ray, you raised a really, really important point, because you've just said that, you know, MACE and DVTs are related to disease activity. So if you just use a low dose and allow for ongoing inflammation, you don't reduce MACE or VTE. But if you actually induce remission and start to taper the dose, that may be a far more sensible approach.
So that's a really important point that I want to reemphasize and reemphasize. Every article that we've all written starts off with rheumatoid arthritis is a systemic autoimmune disease. I pointed out the MACE, malignancy, the DVT. It's all disease activity. It happens it isn't just the joints. It isn't just pain. It's disease, the systemic activity. But if you get systemic disease activity under full control with 2 milligrams of baricitinib, fine. But if it's not under full control, that's problematic.
This is why so many people stay so long on corticosteroids, you know. This is what helps the systemic features for them, at least, not only for pain. For pain, glucocorticoids are not so good.
Last chance for a question, microphones online. Just to finish, a question on cycling. Is there any people cycling from one JAK to another? Would you expect it to be effective?
Peter, you answered that question for me 2-3 years ago, right? And it's been published, and it's been published again and published again. And Jackpot, which is not the greatest study, but it's pretty good, does show the same thing. And that is, and I don't know why it's surprising, if a patient fails a JAK for efficacy, and you switch to another JAK, they could respond. If they fail because of an adverse event, that may be problematic. I think that, I don't remember, didn't we do that with TNFs? Right? Before anything else, that patient failed, you switched to TNF, and actually patients responded. I don't remember, did we do that with NSAIDs? Right? It's the exact same thing. I mean, yes, you can switch.
Okay, I think if we are not having any more questions, I think it remains for me to thank you all for your participation and question, and the faculty who raised to the occasion and answered some of the most challenging questions in everyday practice. But I think it hopes to answer some of your queries and get the right balance between achieving the benefit versus the risk. And I want to thank the sponsor or the funder of this symposium, which is Lilly, and they did it through an unrestricted educational grant, so they supported this symposium by having a direct input on the agenda and what the speaker wants to say. They speak with their own personal opinion. So maybe this is the right way when we want to support symposium for the future, so that we have, as rheumatologists and researchers, have an independent input on how this symposium should be structured. So with that, thank you very much.
If you want to get more information about JAKs, slide decks, PowerPoint presentations, podcasts, log into cytokinesignalingforum.com, and you'll find there's a very good educational resource there that's free to download. Thank you very much.